I want to first hand it off to our moderator, one of our two moderators today, and this is Todd Holloway, and I'm really pleased that I get to actually work with him on the National Council of Independent Living. He is the chair of the Emergency Preparedness Subcommittee. So I'm going to hand it over to Todd to get us started today. Thank you.
Thank you, Sarah Ann. Can you hear me okay?
Loud and clear.
Thank you. Forgive me, folks. I'm on telephone. Hopefully my audio is a little clearer and using less bandwidth. I do want to take a second to thank Sarah Ann for pulling this together, and on behalf of the National Council on Independent Living and our disability rights partners across the country, we are very grateful to have everyone here today. So welcome everybody on the West Coast, good afternoon, and for those of you on the East Coast in our Caribbean territories, good evening. So first off, I'm going to introduce our panelists, or I'm going to have them introduce themselves and tell us a little bit about how their work has changed since COVID-19. So if we could get started with you, Andrew, that would be great.
Sure. My name is Andrew Pulrang. I worked for about 24 years in independent living at an independent living center in northeastern New York. When I stopped working there, I went to sort of doing online disability activism, and I'm one of the co-founders of Group the Vote, the Twitter campaign to discuss disability policy and politics. I also am a contributing writer for Forbes online. And I guess things haven't changed a whole lot for me, to be honest, with COVID, at least in terms of work, because I was basically working from home before. Anyway, the only big difference was that I'm a part-time tutor at my local community college and had to switch over to doing that online. But yeah, and of course, as a topic to be discussing, it's been kind of a dominant thing. So yeah, that's how it's changed for me. Hello?
Thank you so much. David, are you available?
Yeah, sure am.
Oh, Larry.
Thanks, Todd.
Oh.
Or Larry.
Thank you. Go, David.
Okay, thanks. Thank you, Sarah Ann and Todd and Noah for having me today. And Dave Voepel is my name. Arizona Healthcare Association is who we represent. And I spent about my first 12 years dealing with the Illinois Healthcare Association as their CEO. And then came over to the Arizona Healthcare Association about almost 3 years ago. And AHCA represents skilled nursing facilities and assisted living throughout the state of Arizona. And we're also affiliated with the American Healthcare Association and National Center for Assisted Living, AHCA NCAL. So the big difference, I think, on how things changed for my position is that it's all COVID all the time. Quite frankly, we were knee-deep in flu season and hoping to get that through all of that. So we had a lot of infection control procedures and prevention, all that good kind of stuff, education going on. And then we also had our legislative session happening because we advocate for SNFs and for ALs. We were pretty much buried in that. And then one day it all just shut off and it twisted around into COVID. And we had to get schooled up pretty fast on what all that meant. So it's been quite an abrupt change, I'm sure, for everybody, and we're looking forward to getting out of it. So maybe one of these days.
Thanks so much, David. And next, I apologize. We're having a little power outage issue on my end, but Larry, if you are available.
Sure. My name is Larry Polivka, and I appreciate the invitation. I'm not exactly, I think, a policy researcher specializing in disability issues, but our focus, I'm director of the Claude Pepper Center at Florida State University. And our mission primarily has to do with health and long-term care issues for older people, but also to a more limited extent, I suppose, the younger disabled population. Our work has changed primarily in the last 3 or 4 months because we have a greater sense of urgency, frankly, about the need for long-term care reform. And it might be interesting to have a discussion with Dave about this, given the organization he's with. But our focus is on increasing the advocacy efforts around the expansion and diversification of the American long-term care system, which in our judgment is largely, at least compared to other wealthy countries, very ineffective but expensive. And that means that the focus is primarily on advocating for the move of a long-term care program out of the Medicaid program into Medicare. We think it has past time for that, especially now. And we don't see how we're ever going to get the kind of resources we need into the long-term care system for any vulnerable population without that shift. Medicaid is way too limited a funding resource, especially given what's coming in the next 10 to 20 years with the doubling of the 65 and 75 plus populations in this country. So that's been a kind of a shift, an acceleration focus, I guess you would say.
You still happy, Todd? Well, if not, I think I can, whoop. Yellow.
Hello?
Hey. Is
This is Todd. I'm getting through cell. They just cut our power.
I got you. You doing okay? I can take over if you'd like, if you're having some issues on your end.
Oh, that'd be great. Go right ahead. I'll listen until I've got battery backup on the computer at least, but I don't know about internet.
All right. You take care of that. All right. So yeah, just kind of taking over. I have a script here, so I'll read off kind of the intro section. So thanks to everybody for introducing themselves. This is a public webinar, and those viewing the session have different levels of experience regarding emergency management and disability rights, which is the focus of this webinar series. Our first round of questions are to make sure that we're all on the same footing about the problems faced by individuals over the age of 65, and especially those who are also individuals who have disabilities. And I'd also like to just introduce myself. My name is Noah Patton. I'm at the National Low Income Housing Coalition. I'm a housing policy analyst that primarily works in the field of disaster housing recovery, which I think intersects very much so with, the issues of disability, of ageism, of housing, of social justice, as well as healthcare. And I think, if nothing else, this pandemic has really taught us that housing is healthcare when it comes down to it. So I'll just start with a few questions. So this one is for Larry. Larry, could you explain why individuals over the age of 65 are having mortality rates from COVID-19 much higher than other populations?
Well, it appears, and we learn more about this pandemic, with every passing day, it seems. But at this point, it appears that the older population is materially more vulnerable than younger populations, especially when you get into the 70 and then 80 plus. The last I saw, the mortality rate for people who contract the virus in the 80 plus population is something around 10%, which is extremely high as virus mortality rates go. And there are many reasons for that, but it has a lot to do with simply the difficulties around, the impact of aging on the immunity system of humans, and the fact that as you age, you pick up more comorbidities and underlying conditions that make you increasingly vulnerable. I mean, it's been a concern for a lot of us, and I'm sure Dave can talk about this better than I can. In the nursing home area, there's always been this issue of infection, and how do you control, how do you contain it? And that has become an especially salient issue now, given what's happened with the mortality rates in nursing home, and it's somewhere in excess of 55,000 at this point. But we think that's been an issue for a while. We've put out some papers critical of the infection control rules, and we think that needs to be enormously strengthened. But the bottom line here is that the elderly are, especially with underlying conditions, and that would be especially true of older people with disabilities, makes them extraordinarily vulnerable. And extraordinary measures need to be taken to protect them, and we're not satisfied that those are sufficiently in place yet.
Gotcha. Thank you for that, Larry.
Mm-hmm.
Dave, did you want to add on to that just for quick for like 30 seconds? I have a question to ask you myself.
Okay. Larry's spot on. There's a reason why, especially in Arizona, there's a reason why folks are in a skilled nursing facility, and that's because they might have respiratory issues. They have acuity issues, and so they are more susceptible to the COVID virus. And once it gets into a facility, it tends to spread really fast because of that. So Larry's exactly right. It impacts the older, especially above 80 years old, and typically in a nursing home because they have those issues.
Yeah.
Right. And it's not just the mortality rate. The impact on a survivor's health, the older you get, is far more extensive and damaging.
Yeah. Hard to recover from.
Yes.
Great. Thank you to you both. So now the question I was actually going to ask you, Dave. Could you briefly explain what short-term and long-term care facilities are and how these are similar or different from nursing homes? I should be interested in this myself.
Briefly, I don't know how brief I can be. It depends on how much depth you want to go. But anyway, I'll give it a shot here. Typically, nursing home is the catch-all phrase that we use. Everybody uses in the public, the press uses to catch anything from a skilled nursing facility to a nursing home to an assisted living to home and community-based service on top of that. Typically, the differential between a short-term stay and a long-term stay is usually the payer source. Medicare is a hospital-based program, and because of that, they deal with rehab and things like that. So you're talking a Medicare short stay will be in a skilled nursing facility, is usually associated with that. On the Medicaid side, that's where your long-term care comes into play. So you might be there longer than 8 to 10 days or 12 days. You might be there for 2 years, and it's a long-term stay. That's a nursing home. So they're used interchangeably because in states like Arizona, they're licensed for both Medicare and Medicaid. So you can just call them a SNF or a skilled nursing facility, covers everything. And assisted living, on the other hand, in Arizona, and this is different in all 50 states because it's not a federal program, it's a state program. The assisted living is covered by the state and it doesn't have, in the state of Arizona anyway, doesn't have the same caregiving apparatus in place. So that's even more different. So the biggest difference between the two is typically the payer source. And once you have that down and can separate it that way, then you can figure out, okay, which one's a SNF or which one's a NIF, for lack of a better term.
Gotcha.
Does that help?
Yeah, that helps with me. I know I use them interchangeably when I write stuff. So I will make sure to get those right. When I write stuff for NLIC. I just wanted to check in with Todd. I saw you pop back up on our Zoom.
Thanks so much, Noah. Yes, I'm on a different phone, and I actually have internet. So at least I have the messages up that were up. So moving right forward, I'm switching over to you, I believe. So without further ado, Noah, if you want to go ahead with the second round of questions.
Well, I think we had one more question for Andrew here before.
Yes, we did.
I just want to make, I don't want to leave Andrew out. But then
Not at all, not at all. So Andrew, can you explain the role of ageism in housing and during COVID-19 as best you can? I can imagine this is a big topic.
The role of ageism in housing?
Yes. During COVID-19, especially.
Well, that's an interesting question. I don't want to speak out of turn, but I'm more, I don't know. I mean, I think what we're trying to, my understanding of what we're talking about is how to explain what's happening with COVID-19 for people with disabilities, including people who are aging. And
correct.
Okay, so, I mean, I'm not an expert on aging. I'm an expert on disability. And I think there's obviously some crossover there. And I think,
yes, and I'll give you some context, Andrew. This is Todd.
Yeah.
Some of the things that we've run into across the nation is looking at a lot of the effects of COVID having direct influence on people who are aging, but not so much talking about disability. But the fact that our congregate settings are usually considered places where people who are retired or aged or infirmed go.
All right, so I'm just readjusting my thinking a little. I mean, I think one thing that we have to address is some of the rhetoric around COVID-19 that has been active from the very beginning. Actually more in the beginning and a little less now, but I think it's still there. And this is not about policy, but about public rhetoric. And that is the idea that was put out there for a while, that maybe this wasn't the trying to comfort people's fears, I think, by saying, oh, this is only going to really affect people with pre-existing conditions and the elderly, as if that made it less bad. And I think we have to acknowledge that that was out there from the very beginning. And I think it was used as a comfort line to the public. Now, subsequently, that's turned out not only to be tragically true, but also tragically false. So I think even that is kind of falling apart in front of our eyes as we speak. But it's still, even if it was completely true, it's kind of, and I'm not going to mince words, it's a disgusting attitude and a disgusting piece of rhetoric to put out there. Even if it's not meant in a really nasty way, the indirect message is, it's okay, it's only going to hurt old people. And if that's not ageism, I don't know what is. So there's that, right? So, yeah, I think that starts that conversation. You know, and I don't know if later we're going to discuss the pros and cons of congregate care, but that's been more the concrete problem, is that from my perspective as a person with a disability, you know, I've been able to get through this so far, knock on wood, because I am able to isolate myself. And that means truly isolate myself. I have friends, you know, I don't use home care. I don't need home care. But I have friends who do, but they are also able to isolate themselves to an extent because they have home care and they have some control over who comes in and out of their environment. They don't have to contend with other people who live in their environment. And even though they do have to let people in who help them day to day, they have maybe 1 or 2 people to deal with instead of 20 or 30 or 50. And I mean, that there's a math there that just doesn't add up when you're dealing with infectious disease. So there's a limit to how much people can protect themselves if they're in congregate care. And, you know, is congregate care is predominantly older people. That again, that's not an ableist attitude, but it's a disproportionate effect.
Let me add something to that.
Thank you, Andrew. Did we have questions?
Can I add a little bit to that important observation?
Please.
That rhetoric has been very damaging, and it is certainly vile. And it extends into the area of supposedly explicit ethical decision-making about who gets care and how much. And that whole debate began in March with, well, the first criterion will be age.
Mm.
And, you know, there appeared to be kind of emergent consensus around that initially. And then the disability community in particular began to push back more than even among aging advocates. But it's no, that should be the beginning of the ethics discussion, not the first premise that we organize our ethical assessments from. So yeah, you're right. That rhetoric has, it needs to be more contested than it's been. But in terms of housing and older people, look what's happened to federal housing for older people over the last 30 years, for God's sake, in terms of its availability on a per capita basis. It's just been in steady decline for that entire period, and hardly anybody has taken a look, because we've just rolled over to this notion that we're into an austerity period now for decade after decade, and we can't afford these things anymore.
Mm-hmm.
In the richest country in history, at least until now.
Thank you, Larry. Andrew, did you have any further follow-up on that? I personally find the lack of concern around aging in place and universal design is troubling. And of course, now this is just put the cherry on the cake. Andrew?
No, I agree completely. I mean, we're having this discussion, you know, under the auspices of independent living. And, you know, I'll just admit, we come to this latest crisis, we tend to come to this with a pre-existing concern, and that's putting it mildly, about, you know, the balance between congregate care and independent living and help, you know, at home versus being put in either a nursing home or assisted living or group home, whatever definition, a place run by somebody else where you live with people who are not people that you pick. And you don't really have control of your environment, even you know, whatever, on a sliding scale of how much you're able to anyway. So, you know, there's a bit of a bias there on my side, at least with the independent living side anyway. But then this happened, and it really underscores that there are many reasons to look at this whole model. And I agree with what was just said about, you know, housing in general being woefully underfunded, and not just in terms of like who can get an apartment or get it paid for, but construction, the entire housing industry, which again, I am not an expert on, but my sort of layman's policy wonk interest understanding is that the housing industry in the United States is a mess in very many ways, which it doesn't surprise me that spills over into affecting people with disabilities and the elderly, who again are two groups that overlap a lot.
Yeah, and one more point there. The long-term care system in this country, which is primarily funded by Medicaid and Medicaid waivers for home and community-based services, varies enormously I mean, you've seen one state system, you've seen one. And they
Yeah.
vary enormously in terms of the issues that Andrew was just talking about, in terms of the availability, access to home and community-based alternatives. They vary considerably, I think, in terms of quality of congregate care at both the assisted living and nursing home, domains. But the fact is, we do have some state systems in this country, probably approaching, I don't know, 10 to a dozen, that are actually performing pretty well now compared to 10 or 20 years ago in terms of the availability of home and community-based alternatives to congregate settings and to one's own home where they can't live without those home and community-based services. And we've got some states in this country now that are providing 75 to 85% of their services to Medicaid eligible people needing long-term care in the community in one form or another, in-home, community residential, group homes, and such as that. But it just varies enormously. And the difference between Mississippi and Minnesota could not be greater.
You're right, Larry. And Arizona is one of those states to where it's flipped around to where it's 85% home and community based. And the other 15% is a nursing home type. Right. That's why our acuity has gone way up in the nursing homes in the skilled nursing setting. And because they need those services. But you have HCBS that's proliferate.
And it's my impression from trying to track this stuff as best I can through CMS, but it gets a little murky at points now, especially now. You're not getting enough per diem funding in Arizona for your nursing homes.
Right. Yeah, that's kind of nationwide too, but still, yeah, you're right.
Could I chime in on that? Because
absolutely.
Because I do want to say that I'm sort of the anti-nursing home guy. I'm not the only one, but maybe in this group, I don't know. But I will say that it's absolutely true that there's a difference between our long-term vision for long-term care and what needs to happen right now in this emergency. And I would not for a moment suggest that nursing homes don't need far more support or assisted living or any of these congregate care need better support and better policy to deal with the pandemic. Because they are there and there are people there who are either dying or they're not dying, and they need to be well regulated, but they need to be well supplied. And I'm absolutely aware of that. And I don't want anybody's rhetoric from myself or anybody else in the independent living movement to confuse that, because I don't think any of us want to see, anything drastic done that would, or anything negligent done about the people who are where they are. But I do think, again, we need to look long-term at what the implications are for the future, and that we should be going in the direction of the states that have flipped it around, as you say.
Yeah.
Thank you, Andrew. This is Todd, and I agree. I think that we all need to be at the same table together to see that future really come to fruition and be something that we can all agree upon. In the interest of time, I'm going to turn it over to Noah for a second round of questions. I do not want to let this issue go undiscussed. So if we have room at the end, Sarah Ann, I'm going to leave it to you to bring us back to it.
That sounds good.
Thanks, Sarah Ann. And so without further ado, Noah, thanks for already starting us off, but continue, please.
Of course. So I wanted to just touch on the excellent housing insecurity conversation that was happening, just because I do work for the National Low Income Housing Coalition.
Which is an important organization.
Yep. Thank you, Larry. Yeah, I appreciate your enthusiasm and your knowledge on this. So I wanted to say that I typically work with more like traditional disasters, which would be like hurricanes, tornadoes, wildfires, and such. And there you can really draw a direct line between housing insecurity and the level of needs after a disaster. So where a very housing insecure area is struck by a disaster, which disasters tend to strike areas that are already housing insecure, very housing insecure, that knocks out, and the disaster knocks out a portion of that affordable, accessible housing stock. Survivors end up having to move long distances away, away from jobs, away from services, away from families and friends that are necessary, whose contact they need to maintain their mental health. And that, directly relates to how survivors, fare when it comes to disaster recovery. Now on the, for COVID-19, that housing insecurity ranges, the level of its importance increases even more because it's directly related to health outcomes. And I know we've been working a lot to try and help out homeless service providers across the country. And it's just a couple of stats here, and then we'll move back to the questions. But people who are homeless and contract coronavirus are twice as likely to be hospitalized, 2 to 4 times as likely to require critical care, and 2 to 3 times as likely to die than others in the general public. And, if unchecked, as many as 20,000 people who are experiencing homelessness could require hospitalization, and nearly 3,500 of those individuals could die as a result of this pandemic. Now, the solution in the homeless community has been moving these individuals out of more of the congregate care facilities and into non-congregate sheltering, primarily at hotels, through a FEMA reimbursement program that is encouraging that. And that's strictly, that's for the homeless population. But kind of like in that realm of talking about facilities and kind of the susceptibility of congregate care facilities to COVID-19, I wanted to throw this over to David. So recently, an ABC 15 published a list of the Arizona nursing facilities with the most cases and the highest death rates to COVID-19. So in that article, you mentioned that initially facilities were more susceptible to outbreaks because of the PPE shortage. You also mentioned that facilities are now quicker to isolate patients, which I think you spoke about at the top of this call. However, all facilities were facing the same set of challenges. Does anything stand out to you about the facilities with high cases and higher mortality rates?
Yeah, I think the biggest thing, Noah, that stands out is community spread. What we've learned out of the Kirkland, Washington scenario, they were the first nursing home. The Life Care Center in Kirkland was the first nursing home to get it, and it spread like wildfire, not only throughout the nursing home, but you found within that next 2-week period that another 8 to 9 other assisted living nursing homes also got it. And what happened was a lot of the employees go back and forth to different settings because they're working 2-3 jobs. And so they were spreading it unknowingly. And that goes to the second issue, which is the asymptomatic piece of this whole virus. We don't know who has it when you don't show symptoms. I mean, with the flu, it's pretty easy. You're achy, you're sweaty, you're sneezing, you're coughing, you're doing all that stuff. But with this, you could be perfectly fine. You might not have your sense of taste or your sense of smell, but you're okay and you're still shedding virus. And that's what we saw up in Kirkland. So when we say the lack of PPE was really a detriment to stopping the spread, clearly if you can't go in one room who has a COVID patient with PPE donned for full droplet protection, turn around and walk into another room that is COVID free, you're going to be spreading it. I mean, it's just so contagious. And so, and if you don't have the proper PPE or all of it, you're going to be doing some things to make sure to conserve, in other words. And so that becomes quite a struggle. I mean, think about this for a second. If you have a 100-bed nursing home and let's say some of the patients have COVID, so let's say you're going to be conservative on your, or you're going to be very liberal on your PPE use, meaning all of your employees over 100 will have donned full droplet protection. That means you have the face mask, you have the face shield, you have the gown, you have the gloves, you have the booties, you have everything on. Well, you put that on before you walk into a COVID positive room. You walk into that room, before you leave, you doff, you take all of that off, and then you go to the next one. You would go through between 2,000 to 3,000 gowns just in one day. That's a lot of gowns. And when there's a shortage of gowns and gloves, we're still dealing with a shortage of gloves and masks and all that good kind of stuff. And you can't do that proper PPE. You're more susceptible to spreading it around. So that's where the comment came back regarding PPE shortage.
Gotcha. Yeah, that makes a lot of sense. And I think in our work at NLIHC, we've been seeing a lot of those issues at shelters for individuals experiencing homelessness in the same way. And I think that the asymptomatic aspect of it has been troubling us as well, in terms of who gains access to federal funding for non-congregate care. And so it's like, if it's only people that are obviously infected, then that's an issue, because we're not tracking those asymptomatic cases and furthering community spread inadvertently. So thank you for that. Wanted to turn back to Andrew. Andrew, individuals can sometimes stay at home rather than transitioning to a nursing home with the help of supports and services. You wrote how an outbreak can interrupt these services and put both the health and the independence of these individuals at risk. Could you explain how emergency managers and disability rights advocates could play a role in keeping individuals who are most vulnerable in their homes and isolated during the pandemic?
Well, I don't know what the absolute answers are, and a lot of it, unfortunately, is policy matters, which emergency planners really, I don't think, usually get to make policy on the fly. They can't say, well, I'm just going to make PPP happen for you, but they have to be asking.
If they could.
Right, but I mean, you have to constantly be saying, these people need it too, right? It isn't just nursing homes and assisted living. It's the home care industry too, which is a little bit more diffuse perhaps, and less and more apt to be forgotten or shortchanged on that. And I think in some cases you have to look at ways for the actual recipient of care to be supplied, which would be one approach to that. In other words, rather than always focus, say, on a home care agency, maybe supply the actual person who has the apartment so that they can supply the aids that come into them. That may be another avenue to look at. Maybe a different funding stream that funds the individuals to take care of themselves and do it that way, or give them a supply. And I think, again, the other thing, which I'm not sure, I think in some ways is common sense, but I think maybe these days we need to keep repeating common sense, which is that they need to make the people dealing with these folks need to actually know to make it a priority not to have them moved into a facility just because, and again, I'm not saying never, ever, ever. What I'm saying is don't go, which I think a lot of people who don't know better or aren't more in depth on this may simply assume that a facility is more healthy, better, more protective, safer. They look at a person living maybe in a crummy apartment and that looks little shaky to them. They've got an aide who maybe isn't coming in every shift or whatever, and it seems really, really rickety to them. And one of the instincts that people have is, if I could get them into a place, that would be much better, right? And we can argue about whether that's true or not in normal circumstances, but in these circumstances, maybe not so much, and a little extra effort to say, we really need to keep you here if at all possible, not just because that's your preference and that's a philosophy, but now it's because putting you in a facility is going to add X number of people into your environment that you don't have now. You may be having problems in your apartment or your house, but at least there's only 2 people coming in to your environment instead of 20. And if we do, let's do whatever we can to keep you out. You know, I live in a state, New York State, where at least for a time, it was the policy to discharge people recovering from COVID into nursing homes. And I think that was because, I don't know why, but I think it was because there's that fallback idea that this is where you send people where we don't know what to do with them, right? So we're all in a hurry, we're trying to deal with things, it's a crisis, send them to a nursing home. But that was like just before I think it became super apparent that that was maybe the last thing you should do. And again, not because of whether nursing homes are bad or good, we can have that argument, but because in this circumstances, as just been discussed, they have a really, really hard time dealing with infectious disease, especially if they're not well supplied. So I think that has to be in people's minds at least, that, you know, keeping people in their homes where they are, even if that situation isn't perfect, may actually be preferable in a way, even more preferable now than it maybe might have been 6, to 8 months ago.
Great, thank you for that. Any comments from?
I totally agree with Andrew. You know, from that standpoint, it's not about, look at what New York did. You had the governor come out with a proclamation with an executive order that said hospitals have to decompress and nursing homes, you have to take them. I mean, we're totally shocked by that, because you're putting a COVID patient in with a non-positive patient, and it's just going to spread, and we know that, and that's just a ridiculous order. But we fought that in many states, and we continue to fight that to this day. And Andrew's exactly right. You're better off, safer, keeping people at home or in an isolated area, and that's just the way it is. That's the way this virus works.
Exactly.
Larry, were you going to chime in there?
Yeah.
Next question's for you. So.
Okay, a couple of points about this really important issue. I'm wondering what's going to happen in terms of general public sentiment when it comes to entering a nursing home, or to some extent, possibly even other congregate settings like assisted living, as a result of this experience. Now, that's not something maybe that's right on top of us at this point, but it's close in terms of, how the public will react to this over the next several months. The other point I'd like to make, and tie it back to the thing I said in the introduction about how we would like to see this program, long-term care, become under Medicare, which it should have been long ago. I mean, we've got a program for older people, and it doesn't include long-term care. How did this happen? And why does it continue to be the case? One of the advantages of having it under Medicare is that the reimbursement levels are significantly higher, as I think Dave was implying a minute ago, in terms of short, convalescent versus the long-term care stay. But one of the things we'd like to see is a tremendous enhancement in the home and community-based benefit, which you can get under Medicare, and it's going to be a lot harder to afford under the constrictions in the Medicaid program at this point. And when people say, no, we can't afford that, Medicare is too expensive already. Well, we spend less than 1% of GDP in this country on long-term care. The countries of Europe spend 2 to 4%. You know how much of a difference that would make if we went from 1 to 2% GDP on long-term care, which I think we're going to have to do in large measure, even if we're going to give minimal care to the big increase in the population over the next 10 to 20 years. But I think one of the things that would open up is to make home and community-based a benefit, an entitlement, use that term, under Medicare, would revolutionize the way we do long-term care for all impaired populations in this country.
Thank you, Larry. And so kind of the final question of this question arc is actually to you, Larry. So individuals can often turn to nursing homes as their last resort, and they face many barriers to leaving nursing homes. So you mentioned in the Miami Herald a sense of obligation. We should all feel to protect these individuals as best as we can. What does protecting nursing home residents look like?
Well, there are several dimensions to that, and one is certainly what Dave was, or I mentioned in response to one of Dave's observations. If you're going to provide really morally defensible levels of care in institutional or nursing home settings, you're going to have to pay more than we pay now. I mean, the difference between Medicare and Medicaid in terms of nursing home reimbursement, the long, short stay distinction, which is often artificial, is enormous. I mean, Medicare pays what, Dave, 3 times as much on a per diem basis?
Oh, yeah.
Stay, or maybe 4 times. It's that the gap is increased. That's got to be resolved. That has to be that gap has to be narrowed. But I think beyond that, there needs to be, and both Andrew and Dave are getting at this, we have a real crisis on our hands still. The mortality rate seems to have slowed down a little bit in nursing homes, but you don't know what you're going to get this fall. So there needs to be that immediate emergency funding to make sure that these nursing homes are equipped with all the PPE they need about now, in anticipation of what's coming over the next 6 months. I mean, there are some of these immediate interventions that need to be taken, but I would like to see us also keep an eye on the bigger picture that I think makes more visible as a result of this crisis in terms of true qualitative transformation of how we treat older and impaired populations generally. And that's what I meant by a sense of moral obligation. I think we should, as a society, have a sense of moral obligation to do exactly that thinking and preparation.
Mm-hmm.
Could I add something to that? Because I think it reminds me of something that was mentioned earlier, I think, that Dave mentioned about staffing.
Of course.
So he mentioned the rotation or, staff working at maybe more than one facility. And, again, I'm not an expert on the staffing side of things or whatever, but it seems to me that one reason people do that is because they don't get a living wage often from working at one facility, and they have to. They just, well, why wouldn't you? And maybe that's another, again, I feel bad putting out these arguments about how things should be when there's no clear political path to get there, but there it is. If we paid people better so they could work at one facility, sort of, I'm going to say like a normal person who works at one workplace, most of the time, then the isolation situations would be a little bit easier. Not a lot, but maybe a little bit. You'd have a little bit less of that churn from one to another if they were paid better, and they could say, like, I have read about facilities that did an admirable job, and a lot of some of them did things like essentially they locked everybody in for weeks on end. I don't know how much they were paying those people, but that's hard to do to employees, to say, okay, we're going to ask you to commit to basically bunking down here in our facility and not going home for 2 months. Mm-hmm. But if that's what it takes, then you need to be able to pay them the kind of wages where they might actually do that, or any other kind of thing of saying, you can't work at another facility. You have to either work here or not work here. And that just, again, that goes to the wages situation which also is true for home care situations. And in home care too, I don't think we have quite the data that we do in other situations, but my concern even in home care would be people who serve, 5 or 10 clients at different, in a day by going from place to place. And if they were able to get a decent living serving one client or maybe 2, that would cut down on risk too.
Mm-hmm.
And the best way to get the resources necessary to do that, I think, Andrew, And it's really critical. I don't think the quality of care and long-term care is any better than the quality of the staff that you have providing it, presumably. And one way to ensure and maintain that quality is to pay people much better than they're getting now, a fairer wage, and how about some benefits? How about some sick leave, okay? But the only way you're going to get the resources, I think, to really fund it at the level that it needs and is going to be needed even more in a few years is by moving this thing over to Medicare. Where else will the money come from?
Well, I think Larry, what you're talking about is mainly taking all 50 states and instead of doing a hodgepodge of Medicaid programs, taking all that and putting it under the federal government 100% and letting that go that route. Not necessarily the Medicare hospitalization program itself.
No.
That Medicare part. Yeah. That makes total sense.
Oddly enough, we had some candidates for president who were proposing such things.
Oh, who was that?
I'm just saying. Well, two or three of them actually.
Actually, it's still there, I think, to some extent, because as I understand it, maybe we're getting into a little weeds here, but
the idea is still there.
Well, there's a big debate still within the Biden administration about how far to go with that. They've already extended the eligibility for Medicare down to 60, and now there's an internal push, I understand, to go to 55. And, some things began to break open when you begin to have that kind of discussion.
But I agree with you. I think that the big hurdle that we have to get over is the idea that that what we need is going to cost more, and that's okay. Again, to refer back to New York State, we have a governor who is not only progressive on a lot of things, but seems to have a real sticking point where he looks at whatever budget is getting higher and he wants to limit it. And breaking through that idea that a budget going up or costs going up for a thing is not always a bad news. Sometimes it's a sign that a thing is needed very, very badly. It's why people are using it, and that maybe we should be spending more money. But that's a huge philosophical thing that we have to address with the whole country. But there it is. That's what it is.
Yeah, I'd say we see that, at least I do in disaster recovery and things like that, where they're like, well, we can't, help we're always fighting to kind of widen that eligibility, that eligible population. And there's always that pushback where it's like, oh, well, that will cost more funding. We're like, well, good, then that's clearly those people, are in need. And even during COVID-19, you have housing assistance programs that shut down within 90 minutes of opening an application period, like in, I believe it was either Houston or Dallas, where their housing assistance program opened for 90 minutes and then closed because they received so many applications, and it was already done.
Exactly. That's true in the country, and almost every housing program opens up. I'm sorry, go ahead.
No, I was going to kick it back to Todd, but if you want to finish us off, Larry.
Well, I had a point there, but it slipped me for the moment. If it comes back, I'll bring it up.
Sounds good. Well, Todd, I'll throw it back to you for the next round.
Thanks, Noah, and Larry. When you think of it, just let us know.
Oh, I thought of it.
Oh, go.
We have enormous unmet need for long-term care services in this country right now. In Florida, where I live and work most of the time, we have 80,000 people on a Medicaid wait list for home and community-based services. These are Medicaid eligible for the waiver, but it's not an entitlement, so they go on a wait list. That wait list has been growing by 5,000 to 7,000 people for 6 years. Where does that end? Especially when you're talking about a growth in the overall older population in addition to that. So we already have a real crisis of unmet long-term care need in all of its dimensions, whether it's home care services or housing, all of it.
Mm-hmm. And one thing I've seen happen with wait list situations is that the wait lists themselves dampen support for the program. Does that make sense? Like people say, you know, you go to the actual people that need them and say, well, can you help us get more funding? Can you help us to get this program on a better footing? And they're like, oh, this program is dumb. I've waited X number of years and it's never done a thing for me. And no, I'm like, okay, you know, I get the disappointment, but it's like, it gives the whole concept a bad name when that's not at all.
Yeah, also the problem, Andrew, is that wait list amounts, you know, you go to policymakers to talk about it and their response seems to be, oh man, you know, it's so out of control now. If we start trying to make a dent in it, we're not going to get very far and it's going to cost them a lot of money. So we're in a rock and hard place and we'll just continue for now, but we've been doing that for years already.
Yeah, for sure.
So thank you for that conversation. I'm glad to hear it's happening, and we need to continue to have this conversation going forward for many years to come, I'm sure. I'm going to slightly shift gears now and turn to the independent living model during COVID-19. It's still going to be the same base topic, but for you, Andrew, I did want to point out that one of the main tenets for the independent living movement has always been the ability to exercise self-determination. So I'm keeping that in mind, you know, when not only looking at the housing issue, but looking at every one of the issues that we deal with in the independent living movement when it comes to community-based living. So Andrew, for you, as many local jurisdictions have mandated the use of masks, you wrote an article for Forbes about why patrolling who is and who isn't disabled is a tricky issue. Could you explain to us a bit about the article and how individuals can be using or misusing disabled rights laws regarding COVID-19 protection measures like masks?
Right. Well, I mean, I think you have to start with an acknowledgement that there are probably people with disabilities that for one reason or another may make wearing a mask or taking certain precautions difficult. I don't say that I know what those are or that I know for certain that like huge numbers of people are, you know, simply should be exempted. I wear a mask when I go out. In fact, and one of my main problems is breathing. I'm not real fond of it. It's not an enjoyable thing for me, but I wear it when I go out because precisely because I'm so vulnerable to the disease, the virus. I don't want to get it myself, and I don't want my community to have it. So I'm definitely not on the side of saying, oh, you know, mask mandates are a bad thing. But I think we need to acknowledge on the one hand that some people may not be able to do it. They can't even put it on themselves and have some sensitivity to that. At the same time, what I was kind of referring to is that some folks are cynically trying to pursue the anti-mask thing that they disagree with for a philosophical reason or a political reason by using the idea of an ADA exemption, literally printing up little cards that say, "Oh, I'm exempt because of the ADA," which is just, you know, trash. Because, you know, the most legit interpretation of the ADA would say, you know, if a store requires masks in this emergency, and you can't wear a mask, you may be able to get them to help you in some other way, but it doesn't give you the blanket right to go in without a mask. At least that's my point of view. You know, it's not a super nailed down issue, but it's particularly egregious when people misuse it. But that's always a balance, isn't it? Because we know that various disability rights laws and various disability accommodations can be misused and can be, you know, there may be cheaters out there. What I was trying to say is we can acknowledge that, but also not go around personally policing every person we see.
Very good point. Very good point. Any feedback from anybody? One of the things that I did notice, this is Todd, one of the things that I did notice is that they're wanting to crack down a lot on the counterfeit documentation that people are showing to be able to use to go into the community and not wear masks.
That's good. I mean, and yeah, that, I can't, nobody can be in another person's head and say, well, I know for a fact that you are full of it when you say that it's because of health, but the example that I cited, when the person's actual statements on the spot are mostly political, it kind of tells you something, at least it does to me. But again, the answer is not to go around policing people individually in a very, prosecutorial way, because that's another thing that people with disabilities do experience a lot, and it's very oppressive over time, is people questioning our own disabilities and saying, well, you don't look disabled, so I'm gonna put a nasty note on your car for parking in the handicap spot. So it's a balance. It's a balance.
Absolutely, I would agree with that. Any other comments? And know that we can come back to it. So, Larry, in a recent news article, you mentioned that nationally it seems assisted living testing lags far behind that of nursing homes. Could you explain a little bit about your feelings about that and what you think the causes might be? Also, how can emergency managers and disability rights advocates network with others to meet this need?
That was about in an article, I think, as I recall, about 3 or 4 weeks ago. And things may have changed. I haven't seen any indication that it's gotten materially easier to test on a routine basis, as testing ought to occur with repeat testing in assisted living over the last 3 or 4 weeks. It may have changed. I mean, the first challenge, I think, in dealing with what's outrageously scarce resource still, testing capacity, is nursing homes, because that's where the most serious risk is at this point. But it's something that should be occurring on essentially the same kind of basis in any congregate setting, and we're just far away from it. What do we? How many daily tests are we getting in the country now? I mean, I saw something the other day where we're still we need to be testing 5 times more than we are at this point, if we're going to have a proper public health infrastructure in place based on that. And I would hope that these congregate settings would be the first priority for making sure that's available to the maximum extent needed. But it's I have not seen, and they may be able to address this certainly better than I can, but I just don't sense that there's still much of a sense of urgency or priority on this coming out of the administration from virtually every part of it, whether it's CMS or any place else. Now, certainly there is increased testing, but it's far from what it should be at this point, and needs to be as soon as possible.
Yeah, in Arizona, we did a baseline test for all SNFs that included about 27,000 people, all staff and all residents. That's a little bit easier than the assisted living. Yeah. On the assisted living side, we're talking about 70,000. So there's a function of money, who's going to pay for it, because in assisted living, there's no Medicare payment. Most on the SNF side, it was paid by Medicare Part B. On the resident and on the staff side, it was paid for by the state. So it's kind of topsy-turvy in the assisted living realm in Arizona, just because of that, the total amount of people that you need to be tested. But Larry, to your point, there's no game plan. It's like we need to test. Well, so there's no overall game plan on what to do here. We keep going back to the state and saying, hey, we did this baseline testing. We just finished it up. In order for it not to go to waste, we need to continue testing. But how are we going to get that paid for? And how do we want to do assisted living? And there's really no big plan in place. And I think that comes from the federal government. That's a,
Oh,
that's,
yeah,
you know, there's a lack of leadership there, and it's just not happening.
And some of the state governments too. I mean, depending on the state.
Right.
I think now would be a good time to mention also that I don't know whether what we're talking about now includes systems serving people with intellectual and developmental disabilities. That's a whole nother realm, I think, of services that have congregate care settings. And I know a lot of the people that I talk with in the disability rights community are getting very, very frustrated hearing all the stories about nursing home deaths and infection rates, and relatively little reminder that this is also happening in group homes for people with developmental disabilities. It's a different system, which again is another thing that we ought to maybe look at. The pros and cons of having a completely separate system for organizations that kind of do some of the same things we're talking about, just for a different group of people, and their systems of accountability are different and not so good, and maybe even less good as they are for others. So that's another thing too.
Yeah, well, that's exactly right. And even on the assisted living side, we have to remember that some of those that are in the assisted living are doing leases. So from a residential standpoint, they can opt out of the testing. So now your staff don't necessarily, I mean, the state can mandate that they have to have a test in order to work. But you know, you're on the residential end, you've got some more complications on the assisted living, and also on the IDDD side too. You have some more. Again, it's a state by state quilt patchwork across the nation that goes back to what Larry was saying from the get-go.
Yeah, and the unmet need, I mean, I don't spend a lot of time looking at IDD community issues, but some, and I have some background in it. I was back in the 70s and 80s involved in the deinstitutionalization effort and for developmental disabilities that I thought went very well in large measure. But the funding, like all funding in terms of public investments for the last 30 plus years, has declined compared to need. And now in Florida, for example, in terms of the Medicaid wait list for people with intellectual and developmental disability, that's over 40,000.
Yeah.
These people are waiting years. And more people die than get off of it, go to care. And it wasn't too long ago that IDD was actually getting a pretty good support on an annual funding basis. That seems to have gradually collapsed across the state.
Well, I think you've all hit the nail on the head. There's, and unfortunately, from my opinion, this is Todd. From my opinion, the general public is completely unaware of this issue. In the state of Washington, we're working on testing right now that is available and some not accessible in the public for people to do drive-up testing and mobile testing that is going out there. And it doesn't even begin to touch on the issues that you're bringing up right now, which could explode, as we know, into some real problems that then pull resources away from everywhere else in the community as well. No, you go right ahead, Andrew.
I'm sorry. I just wanted to add, again, another background detail that just needs to be mentioned somehow, that, you know, when you get to public perception, all of this is made harder by the fact that significant portions of people are not at all on the same page about what we're even talking about. Right?
True.
About
Absolutely.
this being that there is a pandemic, and that, you know, there's a million reasons why that is, and, you know, we could get into that, but probably not. But yeah, I mean, that just makes it harder. Even people with disabilities and people who are older are not immune to that either. So that's maybe another wrinkle too, you know, how do we communicate to people that we're trying to serve, that we're trying to advocate, that may not even be on board themselves, or their families. It's really, really hard.
Well, you know,
Absolutely right.
And it's been something that has kind of plagued us in the aging area for a long time. It's been this decline of advocacy activity for the last 10 plus, maybe almost 20 years. And I came into these fields of services for vulnerable populations in the 70s, 80s, when there was a lot more activity, a lot more advocacy momentum at play that could really create opportunities for policy changes that I think have been seriously eroded or have been all over the country, most states anyway, in the last 20 years. And when that happens, that means you lose an opportunity to educate the broader public as you have a dropping off of advocacy activity.
Good point.
Do you think that's because of complacency with things being relatively okay or seem to be? And if so, do you think that might, I hate to put it this way, but that this crisis could actually change that in a way that might be good in the long run, like, you know, shake people out of, you know, all is not well with these systems?
I think, Andrew, that is our operating assumption with the folks I work with at the Claude Pepper Center. That for all the frustration of the last 10 plus years in terms of real advances and improvements in long-term care, this represents an opportunity possibly to bring these things back into focus in a way with the general public and the policymaker community that they haven't been in a long, long time. I mean, in my state, and several others that we're studying, the major change in long-term care in the last decade has been the transfer of the Medicaid long-term care program to corporate insurance companies. Managed long-term care, they call it.
Yeah.
And in too many cases, although it's hard to get data on this, both out of CMS, where I just think they refuse to provide it on a readily useful and accurate basis, but also the evaluations that were supposed to have been set up are uniquely useless in terms of actually understanding what's being spent, what kinds of services are being provided, and what kind of impact are those services having on people's quality of life and healthcare outcomes. That's just disappeared in large measure. As Vince Moore, who has been doing research in this area for like 35 years, told me the other day, it's as if when the insurance companies came to town to take over these managed care programs in Medicaid, they hid the data. It's a black box. And the states have in large measure agreed to that. But there's been not enough political pushback on that to actually make it enough of an issue to rise to the level of public perception. So, you know, a major change has been corporate takeover and the disappearance of substantive policy discussions right across the board with these vulnerable populations where that's occurred. And it's occurred in 20 plus states. Beginning, Dave, with Arizona in 1989.
That's right. I was just going to say that. Yes, it's exactly right, Larry. Yeah. Managed care came in, and you notice the difference in what Arizona looks like. We're an 85-15 state, 85% HCBS, and that's because of managed care and what it's done. And the
incentives that are
the
in
incentives,
the
and we don't have the skilled nursing facilities like the East Coast states have. I mean, go to Illinois, where I'm from. They have 800 nursing homes, 11 million people, 800 nursing homes. We have over 6 million people and 148 nursing homes. Now there's no equivalent there, but still, it's
those two states are at the extreme in that respect.
Oh,
but,
big time.
You know, but it's almost as if when you did Arizona, and I tracked that seriously from 91 till about 97 or 98, and was involved in the evaluators of that back then, Weissert and Nelda McCall. And, you know, the first two agencies to take over the managed care program were your public health agencies in Phoenix and Tucson, which is like what, 85% of the game in Arizona
Oh,
plus?
yeah.
And
Yep.
they were run by the public health agencies for over 10 years to get that program on the ground and stabilized. And there were a lot of data. You go to the website back then, and this is back before you had a lot of this, advances in terms of technology, but there were readily available data in terms of cost per person over time and outcomes. That's not there anymore. And they got out, they moved to a corporate model in 1999 to 2001. And, that's when you began to see, I think, underfunding, serious underfunding.
Well, just look at the name of the payer source. Access stands for Arizona Healthcare Cost Containment System.
I know.
It's right in the name. Come on, they're telling you.
Yeah.
So,
I feel like I'd be letting down the side a little bit if I didn't suggest though that I don't think these corporate takeovers are synonymous with HCBS, with home and community-based services. That may be something that they have gone for in Arizona. I'm not aware of that, but those two things are separate issues, or they can be. I'm in favor of HCBS. I'm not in favor of it if it's done in a horrible way. So it's not so much.
I think it's combined. I think it's combined in the fact that the dollars change. So when you funnel the dollars to the managed care organizations, the MCOs, and then they dish the dollars out in order to gain more profit margin, it's more profitable for them to go with HCBS than it is to pay for an acuity model or a skilled nursing center or even a hospital. You'd rather push that out and keep those levels of care reduced so that you could make more money.
And underfunded home and community-based services at that. Because
exactly.
We have some indication from some of the data we've been able to put together that a lot of the people who are in HCBS services are not getting access to enough services to have their needs met.
Right.
And to be able to live in the community with an adequate quality of life.
Okay.
And so what's happening too is with these wait lists, they are not moving people into HCBS as much as they're moving people onto wait lists.
Yep.
Right. Well, yeah, that makes sense.
It is really hard to get people to pay attention to this. It's something else.
And you guys are providing enormously good information right now. This dovetails into a question I have for you, David, and that is you've been following Arizona's COVID-19 data release from the Arizona Department of Health Services website. You want to explain a little bit about what that data is available to the public and how it could be used by member and a member of the public making meaningful use of the data and informed decisions that follow?
Yeah, so Arizona Department of Health Services has a dashboard, COVID-19 dashboard, that they've over the last couple of months, it's gotten a lot better, and it has some pretty good data in the aggregate. You can see the graphs on how hospitalizations have increased, on the demographics, on what demographic it's increased from. Like right now, the 20 to 44-year-old set is the one that are really getting into the hospitals at this point. You can see where the congregate settings sit, whether it's from prisons to assisted living to nursing homes, all the way on down the line. And it really is it's a measure, it's a tool to be able to show where the trends are going. And now we have enough data to really see where those things are. To dive deep into that data it's restricted. So you can't really do that. The CMS, if you have the time, they have a little more data, but you got to really know your way around their nursing home compare website. You have to be able to download their data sets and to be able to sort them out and do different things like that. Because all nursing homes in the nation now have to report their COVID up to CMS by 5 p.m. of the following day. So all of that information is there. CMS releases it every week or 2 weeks, whatever their time frame is on releasing, but you have to get it through a data set. And so that would give you even more drilled down information. So
David, I'm going to stop you right there. This is Todd Holloway. And one of the things I want to bring up is the fact that we're on calls every week that include Red Cross bringing in information from the HHS meetings, and you hit the nail on the head. We don't get to hear. This is just once a week. We do have meetings every day with the partnership, but we do not. They cannot give us that information after they've had a week to be able to have it sent to them. And Mary, who's providing us with that information out of that area of Red Cross, it was on the call that day. So yes, go ahead.
So that's where it's at. I mean, that data is very cumbersome and hard to get a hold of. But on the other side, you look at ADHS, and I know there are other states that are doing a really good job at producing the data and releasing names and doing all that good kind of stuff. When people call and they say, hey, where can I put a loved one, or I have to look for a nursing home for my loved one, I always say call the nursing home, because they're obligated to tell you whether they have COVID in the building. You can look up and see what kind of staffing models they have. You can see where some of this data is coming from, and you can call them directly. And you know what? If they don't answer the phone, you don't want to put your loved one in there. So get somebody who's attentive, who participates in the care with you, who is communicative, that type of thing. It's very important.
And this is Todd. I think the data being able to be readily available is incredibly important, not only for looking at potential placements or avoiding placements, but also to get that information out to the American public on a regular basis so that they can make informed decisions about how we work on this going forward through the CDC and other models. Any other insight?
So Todd, real quick, the other issue here is that the nursing homes are inundated with having to report data. So we just talked about the CDC CMS data report that they have to do. They were probably the last ones that just came on the scene and wanting data. You have county reports that you have to fill out. If you get a COVID patient, you have to go to the county, then you have to report separately to the state, then you have to report to CMS CDC. All of those have different timeframes. The county's immediate. In Arizona, the state, you have 24 hours, and by CDC CMS, you have to report by 5 p.m. the next day. And we keep pleading with them, telling them, we're sending you all the same data. We know how government works here. The left hand usually doesn't talk to the right hand, but for God's sakes, can't we all just get together and use the same report? I mean, it's ridiculous.
Absolutely. That sounds like a truly broken system.
Yeah, this is
Larry.
This is Noah, and I just wanted to say I'm getting flashbacks to working with FEMA for a lot of this.
Yeah, oh my. Oh. Sorry about that, Noah.
FEMA used to be pretty good. I remember back in Hurricane Andrew, FEMA performed very well down here in Florida under very stressful conditions. I mean, that was a Hurricane 5. But you know, I'm wondering why there hasn't been more interest in a congressional initiative to standardize these data reporting requirements at the federal level and a standard way to report them on a timely basis. So
because we took the pandemic playbook and threw it out the window on day one.
Mm-hmm. Well, there is that.
Yep.
Because they don't want Big Brother telling anybody what to do.
Well, and they don't want to know. I mean, I think there are several policymakers for whom ignorance is bliss.
Yes.
Mm-hmm.
And I think that's afflicted our healthcare systems right across the board for several years, including right now, at a time when having this information is more critical than ever.
And again, this brings us back to the question of ageism and ableism. That I think in ordinary conversation, it's hard to talk about because it's so awful, but you do have to come back to the thought that at least for some folks, not only is ignorance bliss, but it on some level that they're probably not even aware of. If they could look back in 10 years and say, gosh, that was a terrible time. Anyway, we're on to the next thing.
Yeah.
They wouldn't mind if all these people died. I mean, and the reason I feel I can say that is this is very much what happened in 1918, 1919. It was a horrible, devastating, traumatic experience. And within a couple of years, people literally forgot about it. They didn't talk about it. It was flushed down the memory hole. And my fear, and I don't think it's unrealistic, is that on some level, that's part of the motivation, is the thought that if we just grit our teeth, we'll get on the other side of it, everybody who's left will just say, oh gosh, that was really awful, and move on.
It's implicit, close to explicit social Darwinism.
Yeah.
Yeah.
Yep.
That's
Exactly.
as our national moral culture now.
And I think we can address it without getting into deep politics too. I mean, I don't think that means we all have to be like super partisan even, but I just constantly, all of us from our own angles, bringing up again and again, this is not okay. It's not okay to just accept it as it is.
Mm-hmm.
I mean, you're absolutely right, Andrew. I mean, what does it say about our notion of human value? Some humans have value, many don't. Really? How did we conclude that? And on what basis in the Judeo-Christian whatever tradition is that justifiable?
Yeah.
They need to be challenged.
Yeah.
Thanks, you guys. Sarah Ann or Rebecca, are you on? I can't see you on the screen.
I think Sarah Ann is
Here.
Oh,
There she is.
hey, Sarah Ann. I had a question for Rebecca. I didn't know if she was on or not.
Oh, no, Rebecca couldn't make it, and it's my fault. I didn't
Okay.
send the questions in advance for them to prepare. So our panelists today, thank you so much for still being here and offering your comment.
Mm-hmm. Yeah, I think Dr.
Fantastic
Sonnenschein
quote.
had a press conference just a few minutes before this program, so it's like, because I saw her on YouTube, and I'm like, I don't think she's going to be a panelist. So
Yeah. But Dave, I have a question, if you don't mind. How do you feel about the preparation of your folks in Arizona now? Because it looks as if a bad situation is going to continue to get worse.
yeah, that's a good question, Larry. You know, part of the issue, that we dealt with at the very beginning was the PPE side. And we convinced Arizona really to lock down before the federal government. So we were already in that mode of locking down to make sure we didn't get COVID in the building. Now we have this surge coming along, and true that that it's impacting the 20 to 44-year-olds more than the seniors, but it's still impacting our population. What we found is
spread among your staff.
Exactly. Yes. And that's where the other issue comes in. So we're seeing a workforce problem, and we're still, so at the beginning, we saw the PPE and that issue really come up. And now we're seeing this workforce issue. And it's just like we're on this COVID roller coaster, the COVID coaster. And it just never seems to end. And we can't get a game plan for, okay, how do we get this under control and go and try and reopen so that folks can see their loved ones? And it's just, it's horrible. But on the other side of the coin, we have this asymptomatic behavior that keeps coming around. And it's like, you can't fight an invisible enemy. And that's what we're trying to do here. And when you do it without the proper PPE and the proper staffing, it just makes it exponentially worse. So
I think that's an interesting, what you said about people wanting to see their loved ones, because there's a nursing home, there's a nursing home in my area, and the independent living center I'm associated with has an ombudsman program that they run. And they took, the ombudsman took a huge amount of heat because the home wanted to bring in hair cutters, a hairdresser again, because their people were desperate to have their hair cut. And look at me. But it was against the rules at that time in New York State, and the ombudsman had an obligation to deal with it. And they made a big stink about it. And you know, the thing that got to my mind was, this is a place, and the facilities in our area have been extremely lucky. I mean, extremely lucky. And yet here's somebody that's in a really, really aggressive way went out to the public to say that they should be able to relax. And I'm thinking, are you looking around the country? You know, are you looking at what's happening, and do you think it's okay running actual, you know, congregate care facility where this is the epicenter of what's going on, to do this? I mean, maybe it'd be fine. I don't know. But you know,
Andrew,
what I'm suggesting is that we're looking at a very large system, and we're discussing system wide. But what I think we're learning is a few bad apples, if you will, can really ruin it in a moment of a quick decision. Oh, I totally agree that we should. That I know Mary Jane here, who knows how to do cuts hair for our people and has for years, so she can't possibly be a problem. That's got nothing to do with it at all. And it just takes one in one home to start a chain reaction. So I sympathize. It's really hard to control.
I totally agree. And if we look at it from a local, again, goes back to our conversation on community spread. If you have a local community, let's say it's, 5,000 people, 10,000 people, whatever the case might be, and the nursing home is the only congregate place there, and you have no COVID there, and you have your employees from that local community, chances are you're not going to get it. So why can't we relax that a little bit, have communal dining, have visitations with glass partitions, and do different things like that? We've been advocating that now for the last 2 months, just to be able to get some to open up, because that just doesn't make logical good sense not to do something like that.
But I'm suggesting we don't really know what makes logical good sense.
You're right.
Don't think that we can say, I don't think, I live in a small city, a rural, not 5,000, but not big. And we've been very lucky, as I say, but people come and go. We have an interstate that runs through us, and all it takes is delivery people from a high COVID place, or somebody going to a party. Bunch of college kids, a month ago decided to have a party, and we saw a spike in cases. And if one of those people happens to also work at a nursing home, there it goes. I agree with you.
I agree. I think we have to have the level of safety that's up there, but we can do that. I mean, we're fairly intelligent people. I mean, we can figure this out, with the right safety partitions.
Yes, we can do it. I think this is maybe where the argument from the side of disability and aging comes into the general public. It becomes way easier for us to do that if we've had confidence that our communities were doing all they can. And this is where it falls down for me.
Totally.
I don't have, right now, I do not
and
have
good
that
leadership.
confidence.
And the leadership. And
Totally.
I mean, we've got state leaders in this country who have apparently not learned a thing in over 3 months.
Yeah. Or learned a thing since H1N1 or swine flu or anything like that.
Exactly.
Of course. Yeah.
Yeah.
So at least, Andrew, in a state like New York, where you've been able to get the rate back to baseline, that gives you a chance to do some of these things. Some of the stuff that Dave's talking about in terms of creating a more livable environment in these congregate settings than they've been able to in the last 3+ months. But you need that overall clarity, sense of, we're in this together. This is how we're going to do it. And I want you to understand exactly why. And we learn as we go.
Yes.
And
Yeah.
with that comes trust and confidence in your public sector and your public officials.
Yeah.
But, you know, I'm in a state where nobody really knows what the state plan is. There doesn't appear to be. And it's total improvisation from day to day, you know, it seems. And that's really undermining.
So, panelists, in the interest of time, to squeeze in some questions here towards the end, I did have, I want to thank you all, but I also want to ask you if there's one question, one thing that you would like people to take away from this when we're talking about emergency managers, disability rights advocates, and this tragedy we're working with is COVID-19. What would be one things you'd like to be a takeaway, one message from you? David, what would that one thing be in your mind?
I would say not to try and reinvent the wheel, because there is so much good information out there. You might have to do a little research and digging to be able to verify that it's good information in some cases, but there's a lot of great stuff that's out there, and there's a lot of accurate things out there as well. So don't reinvent the wheel. We have a program that we call Disaster Ready that we've been doing now for the last 10 years, and it provides nursing home incident command training to all nursing homes in the state. And we put together a behavioral care pilot tool and a toolkit. And we've been pressing that out to our members, you know, about what this means on different disasters. And never did we think of that we would have a pandemic of this proportion. We often think about the flu and things like that, but we thought it would be more on the fire side, more on your traditional disaster, if you will, if there is such a thing. And when putting this together, we really saw that how some of these things play into the whole pandemic scenario. And so we've been really pressing our members up on that to try and, you know, make sure that they're prepared and continue to be prepared, because, you know, let's face it, we might be in this for another year and or more, and we really have to make sure that we stay safe and hunkered down. So, but I would say overall, don't try and reinvent the wheel. It's out there somewhere, just got to find it.
Great advice. Larry, what about that one thing to you'd stress for emergency managers and disability rights advocates?
Well, that's you know, I guess there are several things, but one of the things that we've talked about here and that has come up a lot in other discussions, my own thoughts about this, is that we really need to convince, you know, persuade the public that we're all in this together. And that it's not, as Andrew was talking about more or less at the beginning of this, that it's, you know, that disabled population and they're extra vulnerable, but that's just the way this disability is. That is is not a morally defensible position to take, and we need to challenge the American people and their policymakers on that. Now, we're in it together, and if that's the case, then what should we be doing? Especially to help people who are extra vulnerable.
Precisely. Andrew, last but not least, what one thing would you want to tell emergency managers, disability rights advocates?
Right. I think for both, I would say on the more person-to-person level, do everything that you can everything that you can to enable people to protect themselves, and that remember that isolation in this case is not necessarily a bad thing. Because again, I think one of the things that we get into the habit of thinking for folks who are, you know, senior citizens or disabled, the term isolation has a very bad connotation. And we think, oh, isolation is bad. You know, bad things can happen to people. They're lonely and all that. In this case, I think we need to rethink that a little bit and really, redouble the effort you even normally would to help people stay in their own homes if they're already there, right? If they are in their own homes already, but that's at risk. Certainly don't respond to COVID by saying, well, let me get you into a packed facility. The thing is, okay, you got a lot of needs and maybe this is hard to solve, but for the time being, what can we do to keep you where you are, even if it's not wonderfully ideal? And in any case, a lot of people are going to want to do that anyway. So yeah.
Yeah, isolation doesn't have to mean neglect.
That's right. That's absolutely right. Sarah Ann, we've got a few minutes. Do you have questions? And I'll let you turn it over afterwards.
No questions at the moment, but I would
okay.
like to ask, if because this recording will be available for people after the fact. So if people have questions, please contact me. I'm Sarah Ann Jank at the Arizona Statewide Independent Living Council. So you can email me at my name, Sarah Ann, SARAANN at azsilc.org. And if I can't answer your question, I will make sure one of these fine speakers gets forwarded your question to. So, but thank you, Todd. And I'm going to go ahead and hand it over to Noah.
Got to unmute. Yeah, this is Noah. Just kind of in closing, I mean, I'll say what I would want to say to emergency managers is first, thank you for doing that work. And second, please make sure that you're integrating the services and the knowledge that you have and that you offer across all the sectors, so that you're also speaking with the homeless and housing sector, as well as the disability advocacy community as well, just to make sure that, at the very least, everybody's kind of working off the same playbook about what is being offered, and nobody's playing catch up when it comes to that. I'll also say I want to say thank you again to these wonderful panelists. It's a little later here on the East Coast, but I'm energized. So I thank you for that. And I also just wanted to thank the broader independent living and the disability rights community for really having important conversations like these and having them so early on. I think this was a sector that even before COVID hit the front page, I think you all were having these types of conversations even before the spread became evident in the United States. So I just wanted to tip my hat to you all for your foresightedness and just kind of, your hard work when it comes to that. So thank you for that. And finally, I just for a little bit of a spiel, I'll say that myself, what I've learned working around, air quotes, traditional disasters, is that they commonly affect those most historically marginalized. That community then subsequently receives the least amount of assistance after a disaster, which in turn further marginalizes them. And this condition is, of course, the result of economic exclusion, of ageism and discrimination in housing, and a whole host of other reasons. But I think disaster recovery and assistance programs also present an opportunity to clearly identify these areas of need to the broader population, and present opportunity to develop a system that can correct some of these inequities and to increase accountability, which I think we were just as we were talking about on this call, this is a shock to people's complacency and to their assumption that a system is in place that can handle these sorts of situations. I think during this pandemic, the need for reform is further underscored by the danger that if we aren't able to address this issue fully for all individuals, the pandemic will be actively worse for all of us, within and without within and outside the disability community. But I think first and foremost, it's really the federal government needs to move to implement robust and equitable assistance programs, housing chief among them, because I think every day of inaction puts more low-income renters, seniors, people with disabilities, families with children, veterans, everyone at immediate risk of losing their home. And Congress must act with urgency to prevent this unnecessary, costly, and entirely preventable outcome from occurring. And just one plug, you can visit nlihc.org for advocacy tools and our priorities when it comes to federal legislation. But yeah, I think just, now is the time to act. Well, last week was the time to, 3 months ago was the time to act. I think it's far past time for decisive action on housing, on disability rights, and a whole host of things to happen. So thank you for that.
What do you think the chances are that these issues are going to be addressed much more fully in future aid packages coming out of Congress?
That's a good question. Well, we do have, NLIHC kind of registered $100 billion in emergency rental assistance is necessary countrywide, based on the situation as it is now. So that amount of money did pass the House in the HEROES Act, the latest coronavirus package, and is introduced in the Senate by Sherrod Brown as the Emergency Rental Assistance and Rental Market Stabilization Act, which is co-sponsored by 40 Senate Democrats. So I think, I've heard Republican senators that I think were a little bit cautious when it came to advocating for substantial housing assistance are slowly starting to change their attitudes towards it. And I think that's the result of work by excellent advocates, even here in Arizona, working with your senators. So I just say, I think I'm not pessimistic about the chances, but I think it will require a nationwide effort to really push our representatives on the Hill to institute a robust rental assistance package, eviction moratorium, homelessness funding, and and more. So
well, I think that those are important. I think it's also important that that some kind of push be made for funding to provide services to the long-term care system. I mean, in terms of what Andrew was talking about, in terms of the ability of the people to stay in the community and not go to a congregate place. I mean, we need money in Florida to deal with that 80,000 plus wait list. That is very vulnerable to this thing, especially as it gets traction in Florida now. That's true all over the country. So, that needs to be an explicit component of the next, response to the pandemic and the economic collapse.
agreed.
And thank you, panelists and moderators, so much for being part of this webinar today. I will follow up with all of you by email because I will definitely be taking down our notes from this session. And thank you so much for actually having real tangible action items and really being able to get into the into the weeds with the issues. So thank you all so much, and I'm looking forward to talking to you by email. Goodbye, everyone.
Thank you all. Be safe. Be well.